Good evening, everyone. Just checking out the audio visual. I hope that's okay. I hope you can hear my voice, you can see me clearly, and you can see this board, and you can see my pointer here on the board. So, people who are online, uh, can I just get your nod as to if everything is okay? The audio visual part. I hope I'm audible and visible nicely. Fine enough, fine enough. So I think everything is going okay. So I can just quickly begin with this small area, the spondyloarthropathies. In a simple way, what I would say that these spondyloarthropathies, they are autoimmune disorders. Okay, so it's body's immunity acting against the body. Okay, and these autoimmune disorders tend to involve spondyloarthropathies, spine, the appendicular skeleton, the appendicular joints. Appendages means limbs. So the central skeleton spine will be involved. The peripheral joints, the appendicular skeleton will be involved. And apart from it, these can also involve other systems. So they are in true sense multi-system disorders. But since they are predominantly centered on the skeleton, they become an orthopedics cup of tea, these spondyloarthropathies. Now these spondyloarthropathies, as I told you, they are autoimmune disorders. We further categorize them into two varieties. One is a seropositive spondyloarthropathy, and one are the seronegative spondyloarthropathies. Seropositive spondyloarthropathies are the arthropathies where we know the autoimmune antibody. Like in rheumatoid arthritis, we know that there is something called the rheumatoid factor, which is an autoantibody, or there is an autoantibody that is anti-cyclic citrullinated peptide autoantibody. So here these autoantibodies are known to us. So this will be seropositive spondyloarthropathy. But then there are a group of spondyloarthropathies where the autoantibody is not known to us. But yes, we do know that in these autoantibodies, the human leukocyte antigen is defective. I hope you understand what is this human leukocyte antigen. Go back to your pathology, chromosome number 6, short arm. You have a set of genes called major histocompatibility complex, MHC. MHC codes for a set of antigens that help recognize the body a foreign antigen. The proteins coded by MHC is exactly what we call as the human leukocyte antigens. And mind you, this word leukocyte is a misnomer. These antigens are not just present on leukocytes, they are present on all cells of the body, barring a few like the RBCs. So body is able to recognize its own cells by these leukocyte antigens, HLAs, which are coded by the MHC genes on chromosome 6. Now here we know that the HLA antigens are defective, so that's how we know there is autoimmunity involved. But since we do not know the factor in the serum, we call them as seronegative spondyloarthropathies. And here comes the most important one, ankylosing spondylitis or psoriatic arthritis or reactive arthritis or the inflammatory bowel disease associated arthropathies. So these particular disorders, we do not know the autoantibody in the serum, so we call them as seronegative spondyloarthropathies. So my discussion will be 2 sessions this month, discussing bit of seropositive spondyloarthropathies, bit of seronegative spondyloarthropathies. So starting the discussion with this small MCQ right in front of you guys. Time for you to answer this up. 70 years old lady, she's come to you. There's a 6-month history of stiffness in the hand bilaterally. The stiffness goes worse in the morning stiffness. You can take it up. And this subsides as the patient begins daily activities. No other medical problems? All you can see are bony swellings at the margin of the distal interphalangeal joints. Maybe you can pick up here. So distal interphalangeal joints, proximal interphalangeal joints having some bony swellings. So you have to tell me these swellings are there, this kind of a history is there. So this represents which diagnosis? So Kriptesh, other people watching, may I have some inputs going by this kind of a history? 70 years lady, a 6-month history, bilateral involvement, morning stiffness, subsiding with activity, okay, and then bony swellings, distal interphalangeal joints involved, no other physical abnormalities seen in the examination. Alright, so there's a vote for rheumatoid hand and there's a vote for osteoarthritis of the hand. Okay, Roshni says it's osteoarthritis, but Kriptesh disagrees. He says rheumatoid arthritis. Any more people? Okay, RA. So there's again a vote for RA. A. Okay, so what I can sense, the answer of the house is rheumatoid hand. No, not my choice. I would like to go here with the answer as osteoarthritis of the hand, and I'll just support my diagnosis. How? See, it is not SLE, because in SLE you get a non-erosive arthritis, means there is no real destruction. It's mainly arthralgias, pain. So when these swellings are there, that means there is some kind of a destruction going on. It's not going to be SLE at least. No photosensitivity mentioned, nothing at all mentioned. No other abnormalities seen, which means no skin lesions. Okay, so that takes away psoriatic arthritis also, because arthritis without skin lesions, very difficult to say this is psoriasis. So that also goes out. So obviously we are stuck between these two choices. But why this is my preferred answer, now I'll let you know. Just understand the involvement of the joints in two conditions. When you talk of rheumatoid arthritis, the proximal interphalangeal joint and the metacarpopharyngeal joints will be involved. In fact, MCP joints are the commonest joints to be involved. Although wrist, elbow, knee, ankle, they can all be involved, and less commonly even the hip, the temporomandibular joint, the subtalar joint, the atlantoaxial joints in the cervical spine can also be involved. But never in RA. You should be talking of lumbar spine involvement and the distal interphalangeal joints of the hand being involved. Distal interphalangeal joints involved and you say RA, problems. Distal interphalangeal joints involved, not RA. RA, never can you find DIP joint involvement. Please be very clear. Okay. In fact, even if you go through the diagnostic criteria for RA, the updated one, revised in 2010, you can see there is no morning stiffness anywhere down the line. See, you need to understand the ideology behind morning stiffness. What does it indicate? Generally, we think this indicates an inflammatory disorder like RA. It only indicates that there is active inflammation going on. Even in osteoarthritis, although osteoarthritis is degenerative arthritis, you have phases of active inflammation, and during that active inflammatory phase, you can always have morning stiffness. See, just understand. You sleep, your joints go to rest. You're not moving your fingers. So, inflammatory mediators pile up. You get up in the morning, you suddenly start feeling pain because there is a lot of inflammatory mediators piled up in the joint fluid. You move your fingers, muscle action occurs, fluid is pushed out. Fluid is pushed out, pain goes down. So pain goes down with activity. This is what is morning stiffness. It could be there in RA. It could also be there in OA. So that is why morning stiffness is taken out. It is the pattern of the joint involvement that is giving you maximum score. Please see here carefully. If you have the right pattern of joints involved, the small joints especially, you straight away get a score of 5, and 6 is the score all you need to get the criteria positive. So even if the pattern of joint involvement is there for more than 6 weeks, the duration, what is here, okay, that will be enough to tell you that this is a case of RA. Okay, but DIP joint is never involved in RA, so this is a case of OA. Now if you talk of osteoarthritis in the hand, here classically the DIPs and PIPs will be involved. In fact, DIP and PIP joint, they classically show bony swellings. In osteoarthritis, the characteristic thing is formation of osteophytes, extra bone. This extra bone formation occurs around the distal interphalangeal joints. The thickenings are called Herbendon's nodes. This osteophyte formation occurs around the proximal interphalangeal joint. The thickenings are called Bouchard's nodes. In fact, a very easy way to remember HD, high definition. So Herbendon's nodes you have around the distal interphalangeal joint, and this BP, blood pressure. Bouchard nodes you have around the proximal interphalangeal joint. BP, HD are mnemonics to tell you these swellings that you find in osteoarthritis of the hand. So what are you going to find around the distal interphalangeal joints? HD, Herbendon's nodes. What are you going to find around the proximal interphalangeal joints? BP. So Bouchard nodes around the proximal interphalangeal joints. So these are Herbendon and Bouchard nodes that are classical of osteoarthritis of the hand, not rheumatoid arthritis. So I hope you guys are thoroughly clear with this question. So I would love that in future you answer such questions more in the context as to what you find in the pattern of the joint involvement, guys, rather than thinking about that gross things like morning stiffness which are not specific to our diagnosis. Fine, Jatin, I'll just come to your query also, the way to ask me that particular query in the end. Fine, okay ji. So just moving to another one. Middle-aged female, she's come to you with RA. Now RA would be almost like 3 times more common in the females. So female, she's come to you and she's developed some upper motor neuron signs in her limbs, so that means there is some involvement of the spinal cord. So you have to tell me the investigation that will be best to pick up the involvement. Okay, my volume is coming a little low. I'll just try changing that part up. I hope now it's okay. Better? Okay, so can I have the answer here? You want to find the spinal involvement in RA. Lumbar spine is never involved, so it has to be the cervical spine that is involved. Yes, absolutely right. It is the flexion and extension view. Why the flexion and extension view? Because what you are trying to find here is the atlantoaxial instability. So this is the classical pattern of involvement of the cervical spine in RA, is the instability of the C1 and C2 joints. So in order to find instability, you're going to need a view in flexion, you're going to need a view in extension. So this cervical spine involvement here, atlantoaxial joints, is one involvement where the key finding is instability. So in order to find instability, you're going to need an X-ray in flexion, you're going to need an X-ray in extension. Perfect enough, perfect enough, perfect enough. Boutonniere deformity in RA involves. So can I have this answer please? The Boutonniere deformity. Yes guys, so please answer this up, or I'll just quickly show you the hand deformities you may find in RA. Classical one, swan neck deformity, Boutonniere deformity, and the Z deformity. So what you have in Z deformity, there's a radial deviation you may find at the wrist, but what you would find at the fingers would rather be the ulnar deviation. Okay, so this is the Z deformity. Apart from it, what you may find in RA is a swan neck deformity and a Boutonniere deformity. Now what you find in a swan neck deformity, the neck of the swan, this will be the posture. The distal interphalangeal joint will be in flexion, but the proximal interphalangeal joint will be in extension. This is the swan neck deformity. Now opposite to the swan neck is the Boutonniere deformity. So if there was flexion at DIP, at the DIP you are going to have extension, and if there was extension at PIP, at the PIP you are going to have flexion. So see again, at the PIP you have flexion, at the DIP you have extension. So this is what you get in Boutonniere deformity, opposite of the swan neck deformity. So extension at PIP, flexion at DIP. extension at DIP, flexion at PIP. Oops, sorry, not this one, this one. So this becomes the answer here. Extension at PIP, flexion at PIP, extension at DIP. So if you see flexion at PIP, extension at DIP, this is what you found in Boutonier's deformity. Now my question, DIP joint involved, DIP joint involved, DIP. But I was the same person who was shouting at you here that DIP joint is never involved in RA. And now I am showing you a deformity in the hand where the distal interphalangeal joints seem to be involved. So what is the crux? I'll tell you. The involvement of the DIP joints is secondary. They are actually not involved. The problem in swan neck deformity, there is a muscle imbalance, and this is occurring at the PIP joints. Fine. So what basically happens is that the flexor side muscles, they stretch up, but the extensor side muscles, they tighten up. So as the extensor capsule tightens up, the flexor side stretches up, and these flexor tendons become short reciprocally. So this is what pulls the DIP into flexion. So this contracture occurs because of tenosynovitis. You are absolutely right. So extensor tenosynovitis is classical in RA, and this extensor tenosynovitis contracts the dorsal side, leading to the swan neck deformity. And same thing in Boutonier's deformity. See what happens. You have the extensor tendon going in the center. There is a central slip and there are lateral bands. So this is the central slip of the extensor tendon. And what you may find on the edges are the lateral slips. So what happens in Boutonier's deformity? The central slip ruptures at the level of PIP joint. And when this central slip ruptures, the lateral slips subluxate anteriorly. They go in front. So these pull the PIP joint into flexion, and the extension at DIP is reciprocal. So destruction here also is classically involving the PIP joints. So please maintain that the DIP joint is never involved in RA. In fact, this is a repeat question from the previous NEET PG exam. Boutonier's deformity of the finger, and there is a contracture. Contracture means the deformity is totally fixed. So here you will have to go with an arthrodesis because it is a fixed contracture. But when this deformity is supple and correctable, in order to correct this deformity, you are going to release these lateral bands, and you are going to go with the reconstruction of the central slip. So the central slip you will need to reconstruct, and the lateral slips you will need to cut to bring back the finger to the normal position. So guys, are you clear with the joint involvement pattern in RA? Okay, just sharing with you few more deformities. Capita ulna syndrome, there is a destructive process. Synovitis, tenosynovitis we were talking of, the DRUJ joint is involved. So DRUJ joint is involved. You can see the subluxation of the wrist backwards, the carpal bones going in front. This is caput ulna syndrome you may have in RA because of tenosynovitis. Tenosynovitis, you are absolutely right. And then you can have the hitchhiker's thumb. This is Boutonier's in the thumb. Boutonier deformity of the thumb is called hitchhiker's thumb. Okay, you can have a Manner-Felt syndrome. There is rupture of the flexor pollicis longus tendon because of the tenosynovitis and because of attrition from a bony spur formed on the scaphoid. And then you can have this very classical Vaughan-Jackson lesion. So what you find in this Vaughan-Jackson lesion, there are sequential disruptions of the extensor tendons. Extensor tenosynovitis is classical of RA. Okay, and the serial ruptures start on the ulnar side of the hand and the wrist, and they go on and slowly move towards the lateral side. Okay, so EIP joint, the joint of the index finger, extensor indicis proprius is involved in the end. So from ulnar side to the lateral side. So from this little finger going to the index finger, these extensor tendons are sequentially involved. First involved is the little finger, last involved is the index finger extensor tendon. So this is Vaughan-Jackson lesion. So are you guys clear with the pattern of joint involvement in RA, the hand lesions in RA? Are you guys clear? Can I have the thumbs up? Can I have that yes part from you guys? And I hope you understood the importance of tenosynovitis. It's not a disease directly attacking the joints. It's to a great extent attacking the tendon sheaths and then giving you these kind of symptoms. This particular question was there. The X-ray view that will help you to detect the early changes of rheumatoid arthritis. Ball catches view is the answer. So you can very well see as if you are trying to catch a ball. This is how you take the X-ray in RA to find these classical deformities. Fine guys, fine. So one last question before I send you into the break for tonight. So young female, she's come to you. There's stiffness in multiple hand joints, and you can see the destructions and erosions. Okay, so you can see these metacarpophalangeal joints involved. MCP joints are the commonest joints involved in RA. So with this, the diagnosis. This is rheumatoid arthritis. Now you have to tell me, with these multiple deformities, what will be your plan of management. The patient wishes to know the cost. To tell her the cost, you need to know the treatment. So what will be your plan of management? So can I have some people answering me a little on these choices? Yes. So can I get some answers here? Will the NSAIDs be enough? Or give 3 months NSAIDs and then start the DMARDs? Or start DMARDs along with steroids? Or no, go with those very popular and new TNF, anti-TNF drugs, biological therapy is what we call it. Okay, so there's a vote for the choice B, there's a vote for the choice C. Can I have some more options? B, first 3 months NSAIDs, then the MARDs. Okay. Okay, B. So I take B as the answer of the house. Fine enough. But my answer here will be C, steroids. See, I'll tell you first the drugs we have for RA. What happens in RA? That the antigens of the body, the antigens in the body, the HLA antigens in the body, HLA antigens, yeah, I must tell you, HLA-DR4. These are the antigens on the cells of the body. These antigens undergo abnormal citrulination. So they are citrulinated abnormally. This citrulination of the antigens is picked up by the antigen presenting cells circulating in the body. These cells inform the T cells. The T cells involve the B cells and macrophages. To inform the macrophages, they use interleukin 1, interleukin 6, and to inform the B cell, they use CD20 molecule. Now these T cells inform B cells, they form immunoglobulins. Immunoglobulins, they form anti-cyclic citrullinated peptide antibody, and these immune complexes, they go and deposit in the synovium of the joints, and there they activate a Janus kinase pathway leading to chronic inflammation and joint destruction. The macrophage also activates the same pathway leading to joint destruction, but macrophages activate the pathway by using this molecule TNF alpha. So treatment in rheumatoid arthritis is targeted to stopping the cycle. How? Now, in order to stop the T cells, you can use drugs like methotrexate, hydroxychloroquine, sulfasalazine. Methotrexate, anti-proliferative. It would not allow T cells to proliferate and maximize inflammation. So this is how the DMARDs would work. Chronic inflammation can be taken care by the steroids. They prevent recruitment of the neutrophils to the site of inflammation, so these mediators cannot be released. Then in order to tackle these things, you have biological therapies tackling these cytokines. For CD20, you have the anti-CD20 molecule rituximab. Okay. For tackling interleukin 1, 6 and TNF alpha, you have these molecules infliximab, adalimumab, etanercept. So they are all TNF alpha. Okay, tocilizumab, interleukin 6 inhibitor. We've all run for this drug like anything. Interleukin 6 blocking this macrophage pathway. And then you also have the Janus kinase inhibitors. I'll give you a classical example of this drug, tofacitinib. So these are the drugs we have with us that act at various phases of the cycle. The drugs that act at these cytokines here, they are called biologicals. Okay. So just sharing with you the management plan in RA. First, you categorize the disease severity by a score called DAS28. disease activity score and decide with this whether the score is telling you high disease activity or low or moderate type of disease activity. Now, if there is low disease activity, just go with DMARDS. Disease activity is low, give DMARDS. If there is high disease activity, give DMARDS along with steroids. Now, if the disease activity is high despite 3 months of DMARD therapy, now you shift to biological therapy, or you can shift to genus kinase inhibitor like tofacitinib. So if I go back to my case, there were multiple hand joint deformities. So that means my case was having high disease activity. So I was supposed to start with steroids and DMARDs, high disease activity. Despite this therapy for 3 months, the disease activity would have been high. I would have shifted on to those biologicals, infliximab, etanercept, okay, or I could have shifted on to tofacitinib, the genus kinase inhibitor. So I hope you guys have understood the treatment plan also in RA. A lot more to discuss on this, but for that you will have to go with the plus subscription, more classes there on the Unacademy platform. One question that many people ask me, when you talk of juvenile rheumatoid arthritis, the disease effects, I'll just like to clarify, this term is grown. This is not called juvenile RA. It is now called chronic idiopathic arthritis. So this is the current definition for this term. Please don't take this as RA. It has a very different pattern. Chronic idiopathic arthritis, the children would be less than 16 years of age, and what you will find here is ENA positivity. Very rarely you find the RA factor to be positive. So don't mix juvenile RA with classical RA. That's very, very different. So I hope you've understood what is RA. In the end, I would just like to inform you this word, seronegative rheumatoid arthritis. In this situation, you have the clinical symptoms and the joint pattern suggesting RA, but criteria is not satisfied. The American Rheumatology Association criteria. Maybe because the duration has not crossed 6 months. Duration crosses, score is added for the joint involvement and the duration, and then the criteria becomes positive. So in that particular scenario, it is seronegative RA, and even seronegative RA is treated on exactly the same lines as RA. So are you guys clear even with the treatment path? I hope you've now got this message here. High disease activity because multiple joints destroyed. So here you have to go with steroids. They don't work for 3 months. Go to TNF drugs. Clear enough, guys? Clear enough? So I hope things are clear enough to you. You understood the pathophysiology of RA a little bit. I hope you've understood this cycle also. How the antigen presenting cell activates T cell. These are the major cells that are involved in the destruction in RA. So methotrexate anti-proliferative stops these cells from proliferating. But if these cells are proliferating, they're going to use these cytokines to activate the B cells and macrophages. The B cells are antibody producing cells. They produce those anti-CCP antibodies, damaging the joint synovium by the JAK pathway. The macrophages rather make use of these cytokines to produce the damage and activate the JK pathway. Okay, so I hope you've understood the spectrum of the drugs, and NSAIDs are not disease modifying drugs. They are only and only symptomatic. So they are only to be given in this particular patient to control the symptoms on a temporary or SOS basis. Clear enough, guys? So are you guys clear with the treatment part in RA also? I hope you've heard about these drugs. Okay, so you can click a snapshot if you wish to keep a memory of these drugs also. Fine. Okay, so you wish to read more, interact more with me, I'll suggest that you take a plus subscription. With this plus subscription, you will be entitled to all the benefits of Unacademy, and in case you wish to maximize your benefits, I think you know Unacademy and Prep Ladder, they are a joint venture. You can take the joint subscription also at a very discounted price. Just confronting you with like some of the important batches we have for you that are coming up. This is the All India mock test coming up on April 17. So pack your bags, please give it. The explanations will be very detailed and they'll give you very, very good content. So please make sure that you go ahead with this test. Okay. You can take a light prescription for NEET PG in case your paper is just coming up. Okay. There are practice tests, grand tests also included in the subscription. Okay, and they're available on all kind of apps. You're using an Android phone or a web-based phone, you can access from all types of softwares. For the Prov 1 students, okay, because this is all online material, so you can read it anytime you're comfortable with. So Prof 1 people, this is a batch coming up for you starting on April 20. Okay, you can use this code ORTHOLIVE to get your 10% off in case you wish to subscribe. The price is very economical for you guys. High yield revision batches, MCQ batches coming up for people involved with the INICT preparation, with the NEET PG preparation. Okay, so you'll have all educators teaching you on this, the top educators in the country, so you can opt for it. Okay, the high yield theory batch is also there for the people having the theory exams. Okay, and after the class you can download the PDF notes on the Unacademy app. So whichever class is there, you can press a button and all the PDF notes will be downloaded to you, even if you've not made your notes in the class. I would just like to brief you a word about the clarification batches. There's a doubt clarification batch we have with us, okay, to make sure you go home with no doubts. And then we are also launching the auto daily practice papers. This daily practice papers, after every class, you can attempt few questions to get to know your understanding of that class. So really wonderful features to make sure that you stay a step ahead at very economical prices. So this list of the subscription prices, that is right there on the Unacademy, so you can go through the subscription prices at the app. So thank you for bearing with me. I hope you enjoyed the session. I am definitely there on Telegram, t.me Dr. Mukul Ortho. So that is the link. So any personal question you have, you can catch me up on my email address, okay, or on the Facebook profile. Any academic query you have, this will be the best way. And the best way to stay in touch with me is, of course, to take your Plus subscription. For that you will have to use this code ORTHOLIVE. So you use this code, you get 10% off on the subscription prices. Fair enough to have a pizza as you're studying with me. So any other query from you guys? I hope the session was okay, you could understand, grasp. See you on Unacademy as subscribers. Any more query before I close the session? Perfect enough. So wish you good night. Hoping to see you as subscribers on Unacademy. Bye bye.